Good morning, colleagues. Welcome to ASA 2025 and our session here, MythBusters in Pain Medicine, to hopefully address some misconceptions and improve understanding to have better outcomes and have a better practice of pain medicine. My name is René Prescora. I can serve as the moderator of this presentation or this morning's session. And the first presentation is from Dr. Goloor. And Dr. Goloor, to unforeseen circumstances this morning, is not able to attend this session. So our apologies, and we will start with her presentation, and I'll have the honor to present. So I'm not Dr. Goloor, and I still will talk about PRP, stem cells, and more, to bill or not to bill. Session overview: identify key coding codes for PRP, stem cell, and other biologic procedures, and determine coverage under the CMS Acts. Apply compliant billing workflows, including the use of advanced beneficiary notices in Medicare-insured populations. Differentiate between FDA 351 and the 361 classifications and their impact on billing and coverage for biological products. Implement effective documentation, consent, and self-pay strategies to ensure compliance, and evaluate payer trends, for example, TRICARE commercial plans, to anticipate future reimbursement opportunities. So regenerative medicine is an umbrella term that covers a variety of biological treatments designed to stimulate the body's own healing process. In the pain, spine, and musculoskeletal space, the most common biologic interventions are platelet-rich plasma, PRP, stem cell-based products, and cell-derived biologics such as exosomes and microfat preparations. Platelet-rich plasma. PRP is derived from the patient's own blood. It's going to be prepared, centrifugation, and it contains a high volume of platelets and associated growth factors, as you see in the second line. PRP is usually used for osteoarthritis, especially knee and shoulder, also tendinopathies, for example, tennis elbow and Achilles tendinopathies, and spine joint injections to aid in pain control. It is minimally manipulated in the preparation, like I said, patient's own blood, centrifugation, and then basically re-injected. And it means it's running under the FDA's 361 classification. That means it doesn't require biological licensing, but it still must be prepared and used appropriately, including consent. Stem cell therapies. These treatments use bone marrow aspirate concentrates or adipose-derived cellular products. The goal is to deliver progenitor cells that can modulate inflammation and promote regeneration of the affected body part. Bone marrow-derived products are typically obtained from the iliac crest, getting concentrated and re-injected. Adipose products, usually microfat or stromal vascular fraction, involve tissue harvesting from the fat tissue and enzymatic processing. Because these are more than minimally invasive manipulated structures, and they are considered under the FDA classification 351. So they are biologics, and it means they require an investigation of drug applications. If you want to administer them, that's the IND, for clinical use outside research settings. So this is more than just minimally manipulated, so this falls in a different FDA classification, and this has implications for you and your documentation. Exosomes and other biologic derivatives. Exosomes are small extracellular vesicles released by stem cells that contain proteins, lipids, and RNA. They're marked as next-generation regenerative tool, but are not FDA approved for any indication to the best of my knowledge. Again, I took over this talk. Commercially available exosome products are illegal to market as a therapeutic under the current FDA policy. So please keep this in mind. Clinical promise versus the regulatory reality. Evidence is promising but inconsistent as of now. I think PRP has some supportive data, especially in the musculoskeletal arena, while stem cell and exosome studies remain largely experimental. The public demand has far outpaced policy development. This creates a regulatory and billing gap. Clinicians face pressure to offer these therapies, especially as some of our others are failing, yet CMS and most private payers classify them as non-covered. As a result, billing compliance, transparency, and documentation become critical to avoid any audit or fraud risks and accusation. While billing matters, the science is evolving, what rules already exist, or there is a framework in which we have to operate in. So if you look at the publications, for example, from CMS, it makes clear PRP injections for non-wound indications are not covered and must be handled as self-pay with an assigned advance beneficiary notice. Similar restrictions apply to stem cell and exosome therapies, which are considered investigational. The goal of this talk is to help you understand how to code and bill correctly or not to bill at all, and when offering regenerative therapies to your patients. So CMS, billing rules for PRP. So again, platelet-rich plasma injections for non-wound injections are covered. Platelet-rich plasma, any sites for other indications are not covered outside the non-wound applications. PRP is approved again for transfusion medicine only. This is the P9020 code on the HCPCS. And to keep this in mind that also pooling of platelets or association with polar therapy is not covered. PRP and CMS key point for muscle, skeletal, or spine indications. PRP is non-covered and must be billed as self-pay with an assigned advance beneficiary notice. This is an overview about the different codes. So there's the CPT codes and the HCPCS codes. The use, the coverage, most of them are not covered. And I think if I summarize it, it is for our most dominant indications for pain and body regeneration, it is not covered at all. And you see notes to the right. Medicare billing workflow. Again, most of our patients are the elderly, a lot of degeneration, a lot of need and pain. So if it's not covered, you need to have the patient file an advance beneficiary notice. Again, if this is a Medicare beneficiary, the patient signs and selects option 2. It says, I agree to pay myself. You want to collect payment up front. Do not submit a claim to Medicare, and document in your medical records that non-coverage and attach the ABN copy. Without a signed ABN, so that you actually inform the patient, you cannot bill the patient later. TRICARE, private payers, again we're talking about PRP and stem cells. TRICARE, temporary coverage for knee osteoarthritis, lateral epicondylitis, was their coverage expired last year. Private payers most follow the CMS non-coverage policy as of today. Some experimental coverage through coverage with evidence development models or through the industry are in existence. You have to connect with the institutions or providers. Again, if you have those patients and you think most likely it's not covered or you're not sure and things are changing, verify with the payer policy before scheduling and moving forward. Self-pay and pricing approximates, again, you see some numbers. It's most important, the information in red. This is informational only and not a recommendation. So don'ts of PRP and stem cells. Don't use inappropriate codes. Don't add PRP during surgery when it is already bundled, for example, PRP in some orthopedic surgeries. Failing to obtain the ABN notice for Medicare for self-pay cases, submitting non-covered claims to the insurance carriers, and advertising unapproved, so-called FDA-approved stem cells or exosome therapies to your patients. This opens the discussion. I think for the flow of this morning session, we decided to have all presenters present, and we're going to have a combined discussion at the end. So it's now my pleasure to move to the next presenter, and I think this is Dr. Rosenquist from the Cleveland Clinic Foundation. And let's see, come up. Is Dr. familiar?
Super, thanks. Morning. So I get to talk about G2211, and I don't know about your institution, but at my institution, every single week, I get a printout that says how many times this is being billed by each institute and department, all right? So this is something that is very definitely on the horizon and something that our organization is paying a great deal of attention to. So I'm going to try and talk a little bit about the appropriate utilization of this code and what it was intended to do, and a little bit about how it's maybe not achieving all of those goals, but it's certainly something that we should be taking advantage of in an appropriate setting. So 2211 was an attempt to create a G code to recognize complexity and additional time involved in longitudinal primary care that builds a trusted patient-physician relationship, often involving a single complex condition or all aspects of a patient's health. It's an add-on code for office and outpatient E&M codes designed to account for the cognitive load, communication, and coordination required to serve as the ongoing focal point for a patient's care, and has an RVU value of 0.49, of which 0.33 represents the physician work component. It's not just for primary care, though. There is no limitation on who can bill it. So the things that you have to meet in order to bill this effectively: you need to be the ongoing focal point for the patient's care, providing sustained long-term medical supervision or managing a single complex condition with a continuous plan of care. So as paying physicians, if we're seeing somebody for chronic low back pain, chronic peripheral neuropathy, or other things, we meet that criteria, because typically somebody is sending them to us because they cannot manage that aspect of the patient's care. So it is legitimate for us to bill this. You can only bill it for an office that is outpatient E&M, right? So you can't bill it in association with a procedure, right? And while the relationship is key, it often involves a single serious and complex health condition that requires a physician's specialized knowledge, right? Your medical record, like so many things, the documentation has to support the fact that you're dealing with the patient's care plan, that your relationship is ongoing, right? That it's not just a one-time event, right? And if you're just doing something that is discrete, routine, or time-limited, then you can't be billing it. It's not for use in inpatient skilled nursing or urgent care settings, right? Previously, CMS did not allow payment for G2211 when the associated E&M service was billed with a modifier 25, right? As of January 1st this year, it's payable even if the base code includes a modifier 25, but only when the additional service is an allowed Part B service. And you can see what those things are. That includes immunizations, annual wellness visits, and other things. Who actually pays for it? So this came out of CMS, and this is kind of the downstream impact of the previous effort back in 2021 to expand payment for E&M services, because our colleagues in primary care have often said, well, you undervalue the thinking part of what we do, and you overvalue surgical or interventional procedures. And so there's been an ongoing effort to try and recognize the complex works that goes into taking care of somebody on a longitudinal basis. And as pain physicians, we know that typically we manage chronic care. None of us, unless maybe some of you do, but I don't have a magic wand, right? And all the patients come in and they want me to wave the magic wand and magically cure them. They want me to fix them, right? And I tell them all the time, I said, I'd be happy to fix you if you can get me an OEM catalog and put me in contact with a manufacturer. I'll do the best I can to order some parts, right? But we're not dealing with GMs, we're not dealing with Fords, or other things where we can order those parts. So who else pays for it? Well, commercial coverage of G2211 is variable, and if you keep searching, you find that these things, like so many of the things that we do every day, continue to change. So as I was putting this together, Humana covers it for both Medicare and commercially, right? United Healthcare stopped commercial coverage. That's a big surprise, right? Cigna, Medicare Advantage only. Aetna, Medicare Advantage only. And Anthem, Medicare Advantage only, right? So this is not something that is universal. Traditional Medicare, everybody gets it. And then the other more commercial companies are only cover their Medicare Advantage programs. Again, if it's a discrete relationship or a discrete event, you can't really do it. So you've got to have an ongoing relationship. And typically, if somebody is sent to you for a consultation and you provide the consultation, but are not going to be taking over their long-term care, you can't bill 2211, right? If they come independently to you as a new patient, you establish a plan of care, you're going to provide care for them in the long run, you can bill 2211 with that new E&M visit. There's no specialty restriction, no frequency limitation. There's nothing that says you can only bill it on 3 visits over the course of your relationship with the patient. As long as you meet the other criteria, you could continue to bill it. The deductible and co-insurances do apply for people that come in with commercial insurance, and it can be billed with telehealth. Although we have no telehealth right now, all right? So all of you are aware that with the government shutdown, the telehealth coverage expired, right? And different people are taking different approaches to this. But it's the first recognition of the additional effort to provide ongoing longitudinal care for a specific condition or overall health. Although tempting to use for all patients, there are rules and it needs to be billed correctly. So don't just put it on every single patient. Certainly some settings, the physicians are not doing the coding and billing, and somebody else who's got coding and billing expertise is doing it for you. Some places you are doing it, and I've got some people, some of my surgical colleagues say, well, I just add it to every single E&M visit, and the coders will catch it. And I keep telling them that's probably not the best thing to do, because they may or may not know what the relationship is, or they may not have the time to read every one of your notes to say, this is ongoing longitudinal care. One of the frustrating parts from the standpoint of physicians all over is that CMS overestimated its use, and the implementation of G2211 contributed to a 3.4% decrease in the Medicare physician fee schedule, and that started in 2024. This disproportionately impacted specialties that are less likely to use the code, but the other things that are frustrating about it is that because they overestimated the utilization and they cut the payment per RVU value, right, there has been excess money left over, right? And there's ongoing advocacy to try and get them to return that money into the payment pool, but they have thus far not been willing to do it. So they got a cut. They generated an excess pot of money that they have not returned back into the physician payment pool. But this is an ongoing conversation and ongoing efforts, and it's not something that is just coming from paying physicians. This relates to all physicians who are paid in an RVU model, right? I would encourage you to use this whenever appropriate for payment in the Medicare system and elsewhere, because as they continue to cut us down, we need to get paid for the things that we're doing, the work that and care that we're providing, and not let dollars sit on the table that we could otherwise be paid for. So thank you very much for your attention on this, and move to the next presenter. And what's my line?
Yeah, I was going to say, full disclosure, I'm not Dr. Warnkamp. He couldn't be here due to clinical obligation. I'm not as dashing at him as him, or neither do I have over a decade of experience, but I'll try to do it some justice. It's really try to go forward. Okay, I have no disclosures, unfortunately, so far. Hopefully that'll change in the next couple of years. So we're going to talk about the trigger point injections and using ultrasound guidance for that. And in order to talk about that topic, we'll generally review some of the Medicare requirements for trigger point injections and how a multi-society guidelines have resulted in efforts to promote ultrasound use for safer injections in complex anatomical regions, and some of the, just a brief summary of the scientific evidence to support that. So trigger point injections are used for local muscle pain after conservative therapy has failed for diagnostic purposes and with clinically confirmed trigger points. So you have to document that appropriately. And I always tell trainees that documentation is everything. If you're not clearly documenting in your physical exam, and sometimes the prior authorization or your front desk is just sending your clinical note to the insurance company, and they're looking for that taut band of muscles and all that kind of verbiage in your note. And if they don't see that, they're going to deny that prior auth. And if you have done a trigger point and you're about to repeat it, you obviously have to document at least 50% pain relief lasting for 6 or more weeks. And in addition to that, pain relief is not sufficient, just like most pain procedures nowadays. You also have to document that it led to increased functional improvement or improved quality of life, however way you want to word that. And then Medicare generally limits it to 3 sessions a year. Some plans allow a max of 4 a year. Some of the private payers I did a prior authorization on recently, they told me that they'll allow up to 4 as long as patient has shown that they are getting benefit from that. Although that also reminds me of another prior authorization with a private payer recently, which is a growing trend. I got on the phone with this payer, and they were covering the trigger point injection for this patient previously, and then they just straightforward told me, like, we're not going to pay for it in the hospital-based setting. Because I work at a hospital-based clinic, and there was no questions asked, so that's a growing trend, just to bring up for everybody's attention. So your documentation must include pain scores, functional assessment, the relief duration, and the evidence of rehabilitation, or documenting that the patient is participating in a home exercise plan or regimented physical therapy. That's another caveat to that. You can document everything else, the pain relief and all those things, but sometimes they are also looking for that verbiage, that is the patient currently participating in home exercise plan or regimented physical therapy. And I think that applies to any kind of pain procedures. So when it comes to trigger points, as you can see, I'm sure we have done, or a lot of people in this room have done like hundreds and thousands of those. You could do it obviously at multiple different targets, ranging from head and neck all the way to the lower extremities. Just by raise of hands, how many of you have done at least a few in the neck, shoulder, and posterior chest wall region? Oh, only a few. I was expecting way more people. So as far as some of the limitations are concerned, TPIs are not covered when used in conjunction with biologics. So just a presentation earlier, you can't inject PRPs and any other stem cells into muscles, and you're not going to be able to get coverage for that. And also, according to Medicare, you cannot bill for multiple anatomical regions. You can't be doing like cervical spine and shoulders and lower back or gluteus muscles at the same time, so try to restrict it to either the upper body or the lower body. The fluoroscopy or MRI guidance is not covered. Ultrasound guidance remains investigational. These restrictions were essentially put into place to prevent the overuse and basically promote appropriateness for repeat trigger point injections. So there's moderate evidence supporting that TPIs work well for refractory myofascial pain. There's some mixed data about long-term outcomes for these patients. Ultrasound guidance definitely enhances safety and accuracy, especially in high-risk anatomical regions like the neck and the thoracic area, because you're obviously at higher risk for neurovascular injury, and in case of posterior chest wall, pneumothorax, there's high incidence for that. Major societies provide structured recommendations for trigger point injections and its use in pain management and how often the injections could be repeated. So a coalition of pain societies, including the IPSIS, I think the letter was drafted by IPSIS, but it was sponsored by ASA, ASRA, NANS, the Academy for Physical Medicine and Rehab. So they drafted this letter urging the Medicare administrative contractors to reconsider their coverage determination for ultrasound guidance in trigger point injections. The latter emphasized the importance of ultrasound in enhancing the safety and accuracy, particularly again in the high-risk anatomical regions such as the neck, the gluteal muscles, and the thoracic area. It referenced a July 2024 multi-society guideline that was published that supported the ultrasound use to improve targeting and reduce the adverse events for these injections. The advocacy effort, this basically highlights the need for policy update to reflect current clinical practices and evidence and to improve patient outcomes. So some of the summary for those from that letter and the 2024 guidelines. Again, the use of ultrasound should be allowed in areas which are considered high risk and high risk for neurovascular injury, high risk for pneumothorax, and some of the specific muscle groups you can see over there. And it's especially important in doing injections in some deeper anatomical structures, and especially, personally, I've seen of some of the obese patients, you clearly don't know, like sometimes if you're injecting a muscle group, you might be just in the fat and not really doing a true trigger point injection. So the utilization of the ultrasound can help with that. And there's at least grade C recommendation from the multi-society guidelines for use of ultrasound for these high-risk patients. And the MACs are urged to review the new guidelines and evidence for ultrasound guidance. I would mention that when you're using the CPT code for the global, I think it's worded as global needle placement for injection, you want to use the 76942. The 76937 is no longer valid after December 2024. So use the appropriate code. So key takeaways, again, TPIs are recommended for documented trigger points after conservative therapy fails. The proper documentation is crucial. Ultrasound guidance is advised for high risk or deep anatomical structures, although it's been considered investigational by some of the private payers and to some extent the MACs as well. Integrating TPIs into multimodal pain management aligns with the professional society recommendations for safe and effective patient care. Thank you.
We're coming to the last presentation of this morning. So again, my name is René Prescor. I practice pain medicine and anesthesiology in Gainesville with the University of Florida, and I'll be talking about there are no limits, how often I repeat facet joint RFAs. Going to the next slide. Disclosure, I have no financial conflicts with this presentation. And I'm also not a billing expert, so please keep this in mind. The references are listed at the end of this presentation. Objectives of my talk is we'll review factors determining how often you can repeat spinal facet joint radiofrequency ablations with focus on billing and reimbursement, not necessarily on the clinical outcome. So it's billing and reimbursement. To review spinal facet joint radiofrequency ablations, so this is a minimally invasive procedure to help with axial, back, and neck pain, and it's treating specifically the facet joints or AZ joints. And you look at the right, you see a joint depicted, and you're going to, I don't know if you see the right button. Bottom line is of this image is that the facet joint usually is innervated from two branches. So there is a descending branch and an ascending branch from the spinal nerve below. So usually if you want to denervate a joint, if you're talking about the spine, you most likely have to place two needles. We'll see about this discussion later. Moving along, the radiofrequency ablation here you see is usually done under image guidance, that is accepted CT guidance or fluoroscopic guidance. It should be a thermal lesion, so it should be at least 80 degrees centigrade, so usually pulsed or lower temperatures are not accepted. If you get an audit by insurance carrier, they will not cover this. So this is just an example picture. And to be fair, this can be done on the entire spine. So you just saw images from the lumbar spine. You can do it cervical and thoracic. Prior to the RFA procedure, there's a prerequisite based on evidence-based medicine. So from our societies, our research, and also from the insurance requirements, that you have to have successful diagnostic medial branch blocks to identify the underlying facet joint, which might be part of the problem, or if it is not. So this is still a prerequisite. Our pain societies have developed guidelines based on our research and reviews, and this is a guideline for the cervical facet joint radiofrequency applications, and this is a guideline for the lumbar facet joint RFAs. Again, clinical guidelines, not necessarily billing guidelines, but they may go hand in hand, and that's also, I think, still the practice you should follow. So those are the guidelines. There's also a guideline from the American Society of Anesthesiologists, together with the pain societies, regarding the statement of anesthetic care during interventional pain procedures for adults. Most minor interventional pain procedures only require local anesthesia, and deep sedation or general anesthesia is rarely indicated. So RFA is one of those minor interventional pain procedures, so usually automatically billing for anesthesia more than moderate sedation or local anesthesia is not indicated, and a lot of times it's not covered. Now, it's pain patients. There may be exceptions. If you want to try this, again, you have to pay attention why you're doing it. That means documentation. CPT codes for billing and communication with your insurance carriers, including CMS, are established. You have the 64633, the 34. Those are 1 or 2 joints for the cervical or thoracic area. Pay attention, cervical or thoracic. And then you have 2 more codes for single joint or 2 joints for the lumbosacral area. So those are the separations. So important considerations. You can do bilateral procedures. You use the 50 modifier, so this is appropriate. Image guidance, as I mentioned, should be used. That is CT and fluoroscopy. It's not ultrasound. It's not MRI. I think can do that, but it's not ultrasound. And the anatomic location, be sure to use the correct code for the spinal region. So it's not an anatomy course. Insurance carriers, especially CMS, decided they're going to lump the cervical and thoracic areas together, and then they compare this to another one. This is the lumbosacral area. So you need to pay attention which area you're treating and which code you're going to use. It's also important to understand it's per joint, not per needle placement. We saw the very initial pictures. Usually there are more than 1 nerve or branches involved to innervate one of the facet joints. So it's not how many needles you place, it's how many joints you treat. So 2 needle placements doesn't equal double the code. It's still 1 code if that's appropriate for the joint. Also, guidelines state that 3 or 4 level procedures or more than 2 joints are usually not indicated clinically. Now we can discuss it amongst us clinicians. However, it is not covered. Also, you need to document more than just the pain score before and after. You also need to document disability, functional outcomes when you want to proceed with those procedures or you want to repeat them. So what are the outcomes? Just spinal facet joint radiofrequency ablations. I know there's a lot of controversy going on. There was this year a new article in the British Medical Journal from, I think, Jason Bussey that nothing works. Again, we can defute this. This is part of this topic. I think if you use the appropriate patient, the appropriate technology, we have shown over and over, it is effective. So as the slide says, complication rates are low. Relief usually 6 to 12 months, so it's not forever. Nerve score back pain can come back. Also, degenerations can proceed or progress. So careful patient selection using diagnostic blocks is critical for optimal outcomes. So we can provide it in the future to our patients. And the good news is, if it fades the effect and you think it's the same pain in the same area of previously, you can repeat the radiofrequency ablation. Yes, you can. There is scientific evidence. Usually these should have relief at least for 3 months. Again, that's the science, not the billing behind it, to repeat the procedure if you think it's the same anatomical area. You also don't need to do another diagnostic block. You already had the proof of concept. But how frequent can you now do it? Every 3 months, once a year, once every 10 years, every month? How often you want to, or individual approach? We don't know. Let's look what goes on in this regard. How often can I repeat a facet joint radiofrequency ablation? I will be honest, the first consideration is, again, of course, the feedback from your patient. If it didn't help, or it's just 2 weeks, it's more negative, again, it's probably not the right appropriate therapy. It just has failed. That's fair. So now if the patient said, hey, this was great, this was a game changer, I haven't felt so good the last 5 years, and it's just 4 months or 5 months, then where are we at? Can we just repeat it or not? So second consideration, as it is in our healthcare environment nowadays, is the health insurance requirements, and there are different from our clinical guidelines. I think is in part also cost control. So the key player is, who drafts those guidelines, is the CMS, Centers for Medicare and Medicaid Services, and most other insurance carriers follow those guidelines. So if that's important to understand. So they have a local coverage determination. So here you can look it up online. It gets updated. It's available for everyone, and it's about facet joint interventions for pain management. So repeat, facet joint RFA in the same anatomic side is considered medically reasonable. Again, if you had at least 50% pain improvement for at least 6 months. So this is what CMS says. It gives you guidance, what gets paid, and that means for each covered spinal region, and they're going to separate between cervicothoracic and lumbosacral, you should no more than 2 radiofrequency sessions will be reimbursed within a rolling 12-month period. And if you think about initially the smaller print for 6 months, so basically you could repeat them. If you and the patient agree that it was effective, it's the best way to go every 6 months based on the CMS guidelines. Commercial insurances frequently follow CMS coverage determinations. Again, review the individual policies. Conclusion, facet joint radiofrequency ablations can be repeated. Just because you need to repeat them doesn't mean the therapy failed. That's important to understand. Patients, of course, want to be fixed now and forever. If they ask me that, I'll tell you need to find someone else. I will fail you on that. That said, we can have maintenance therapy to really help you keep on moving. So keep that in mind. However, for reimbursement, the physician needs to follow insurance policies, frequently limiting the radiofrequency sessions to no more than 2 per rolling 12 months per anatomic region. And again, those are only 2 in the spine. The one is cervicothoracic, the other one lumbosacral. This is the literature. Thank you very much for listening to my presentation, and I think I can bring my colleagues to the podium, and we have a few minutes left for questions. Yes,
for Dr. Rosenquist, the G2211, are you advising like your group to be using it in new patients, or is it really once it's just follow-ups and you know you're going to have that long-term relationship? Because it's a little hard to know when you first meet someone, right?
Right. So I think you look at whether or not you're going to establish a relationship. So if somebody comes in new, it's not a consult, right? And you develop a plan that might be, I'm going to do a procedure, or I'm sending you to physical therapy, or something else that implies that you're making recommendations for which you want them to come back and be reevaluated and provide ongoing care for that condition, you can legitimately bill the 2211, right? Whether it's Medicare or commercial. And I would encourage people to do it in the commercial setting. You can see whether or not it's going to be billed. I mean, it's going to be in their LCD to cover, but you don't know that necessarily because it's a changing thing in the commercial insurance world. But an RVU is an RVU in this world that everybody's trying to chase after us. So I'd encourage you to use it in that setting.
And then the reason not for a consult, do you mean if you think you're just going to see them once and send them back as opposed to just a consult?
So a consult, the way that they view a consult is if somebody's sending you a patient for a consultation, it's to get your opinion and your recommendation, right? It doesn't guarantee that you're going to have an ongoing relationship with that patient. The referring physician is going to read your consultation, and they may elect to send them back to you, or they may not, right? So I think in the consult setting, we should not be billing it, especially in the Medicare. So even though they're a Medicare patient, if my orthopedic surgery friend sends somebody to me for chronic knee pain after total knee arthroplasty as a consult, and it's written in there with an order, I will not bill 2211, right? If in the course of our conversation, I make a set of recommendations, and that patient then comes back to me for a subsequent E&M visit, and I'm going to manage them, then I'll bill the G2211 for subsequent visits.
And then is there any way, I wasn't aware of the commercial coverage. I thought it was all Medicare. Is there any way to kind of stay on top of that and know who's approving it, who's not approving it? Like, where does that information come from?
You can keep checking with our friend Dr. Google. But the other people that are really staying on top of it is internal medicine and family practice. So the family practice site is consistently updating their information with regard to which commercial carriers are covering it.
Okay,
Right?
thank you.
Yes, please.
Not a G2211 question, but for patients that are on chronic opioids, can I argue that they are on drug therapy requiring intensive monitoring, and therefore can I bill that as a level 5?
I don't think that you can bill it for a level 5 unless you meet every other criteria. And I think if you look at what's happening right now, Cigna, as of October 1st, came out with a policy that they're essentially going to automatically downcode level 4 and level 5 visits because they think that people are frequently overcoding. And I think, to be honest, I think most of the time, if you look at our clinical practices, the number of patients we push through in a given day and the amount of time that we spend, we rarely, if ever, meet the criteria to bill a level 5, right? And I think, from an audit standpoint, whether it's Medicare or the others, unless you have really good documentation regarding a level 5 bill, be careful.
I would add another comment, and maybe Dr. Rosenquist can correct me on that. So I think he talked about when not to bill the G2211 if you're doing a procedure during the same visit. Better to do the 25 modifier. And it has happened at our institution because the Epic will kind of alert you, hey, please go ahead and bill the G2211. And some of our APPs, even if they're doing a trigger point injection, they'll try to bill for the procedure and for that code as well. So it's better to bill just for the procedure. And I don't know the exact reimbursement value, but you probably get paid more with a procedure with a 25 modifier rather than billing with the G2211.
That depends. Because we get paid so little for doing a trigger point injection now, that there's not a whole lot of difference between billing a 2211 and billing 1 to 2 site trigger point injection. But there are some things where you can bill the 25 modifier, but there's an awful lot where you can't. So.
Yes, please.
Is a facet joint injection sufficiently diagnostic for RFA?
So they decide between, let's say, purely diagnostic with local anesthetic versus if you use any other therapeutic intervention like adding a steroid. So you have to review your policies, and that may not be considered that. It may not be diagnostic. It's called a therapeutic, and that's when the time is clocking for repeating this intervention.
Yeah, and for the Medicare LCD, if you're going to do intra-articular injections, right, you need to document why you're doing it. Yeah. So if you're being asked to do it as part of surgical planning, right, to say, I'm thinking about doing a fusion at this level, you need to document you're doing it for surgical planning. If you are doing it for therapeutic purposes and you're going to incorporate a steroid in there, then you need to document why you're doing an intra-articular injection instead of an RFA and why you think it's a safer thing. So, for example, you had a young person and you didn't want to denervate the paraspinal musculature because they had a physically demanding job, right? That might be sufficient evidence to support doing an intra-articular local anesthetic and steroid injection. Right? On the other hand, in a 75-year-old, you may or may not be able to make that same argument, but certainly you want to make sure you document the reason that you're doing it. And then the same thing, if somebody had a really good outcome, then you can go back and do it again, right? But you've already set up that precedent by documenting what you're doing.
So if you want to avoid the RFA to follow up on a 75-year-old gentleman, let's say they have an implant or cardiac device, you could argue this way. But again, you have to document, you have to give a reason why you decide on this pathway and not the RFA.
Right. They keep making it harder in all these things that we're doing, and some of this stuff doesn't really make sense other than they're trying to reduce the payments overall. And so on tomorrow, Cigna just came out with a draft LCD that would essentially block access to all peripheral nerve blocks and the genicular RFAs. And it's really potentially disturbing, and it would impact 38 states as it's currently written. And as you've heard repeatedly, there's the potential that if one Medicare advisory group picks it up and does something with it, pretty soon all of them. So this is something that's on the Carrier Advisory Committee agenda for Tuesday here, along with the Committee on Economics. And this is where we keep fighting back. And I think somebody made a reference to the multi-specialty pain work group, which is a group that is representing all the societies to try and speak with a unified voice. And so they are going to be commenting back to CMS about this draft policy and really trying to push back. But this is where, if you have a relationship with your carrier advisory committee, or you realize that there's a meeting and you can provide a voice, please do so, right? To the extent that we're silent, they will just run over us.
Yes, please.
Could you clarify about the radio frequency billing for the thoracolumbar region? Now we talked about the cervical, thoracic, and lumbosacral. So like L1, L2 constituent gets supply the T12 and L1. So the T component comes in as compared to T12 L1 constituent.
So to the best of my knowledge, the T12 L1 scenario should be built under the cervical thoracic CPT codes. So it's the 33 and the 34. And then you have it if you go above.
But it depends on which levels you go. If you go T12, L1, L1, L2,
joints.
then you've got
Joints.
One thoracic, one lumbar.
well,
If you
it's hard because you've got an add-on code. Because you can't build two primary codes at the same time. So I would say that, like so many things, you need to decide what you are, right? And I would say that if you're doing T12, L1, and L1, L2, I would probably go to the lumbar codes rather than the cervical thoracic codes. And it used to make a big difference. But the last time those codes got surveyed, the primary value was the same for cervical thoracic and lumbar sacral. So you're really not going to gain anything from an RVU value standpoint. And the subsequent levels also remained the same without harm. So you don't really gain one thing or another. It's just you need to decide what you are that day.
And if you have the T12 L1 joint, that's under cervical thoracic. So that's where Medicare was clarifying it.
Yeah.
T12 L1 joint.
Yeah.
We have a group of folks who just love botulinum toxin and to include it in their trigger point injections. Is anyone paying for that? If so, how are you coding it?
I don't believe so. That's not covered currently when combined with the trigger point injection.
Yeah. Medicare doesn't do it. Medicare, in fact, has really started to crack down on any additive to local anesthetics for trigger points because they convened a group to look at the evidence around trigger point injections, and there's very little evidence to support the addition of additional compounds to local anesthetics in terms of outcome, durability, or improvement in function. And so they say they won't pay for it. So if you put something in there, so if you say, I'm going to do my trigger points with local anesthetic and Depomedrol as an example, and you put that in your note, you may get through the first billing process, but if they come back and audit you, you will have to give the money back in the current LCD.
And I think it was also a recommendation by the societies as well not to use any additives for trigger point injections.
Yeah.
Because that's, I mean, I always tell trainees all the time that this, you're essentially negating what you're trying to achieve with the trigger point by adding steroid. But I understand there's a lot of patients who think like it works for them. They come to me, they're like, would you add steroid? And I'm like, I'm not gonna do it. And then they'll leave.
Yeah, sometimes, the creative billing that we do tends to hurt us in the long run. And so when we see things that are coming down the pike and they become more widespread and new, if we get the evidence around them, we can work on creating new CPT codes. But when people just try to stretch an existing CPT code, typically it creates an increase in the volume. It can generate then a survey, and typically when we go to survey, we are lucky to maintain value and oftentimes lose value. And so just as an example of a recent thing, as a member of the COE and as the RUC advisor for ASA, we get lots and lots of inquiries about billing. And people don't like to use a 64999 unlisted code for things. And so people have been massively enlarging the number of fascial plane block codes over the course of the years, right? And you've got a QL1, a QL2, a QL3, a PEC1, a PEC2, right? A serratus block. You've got all these different things, and because they weren't described, right, they tried to use other codes, and those created problems, right, because they didn't want to use a 64999. So ultimately, I pushed to get the other societies involved, and we said, let's do it by body region, because who knows how many new thoracic codes are going to be developed, or abdominal codes are going to be developed, or lower extremity codes are going to be developed. So let's just talk about the general work, the use of ultrasound guidance, and putting local anesthetic in existing fascial planes. And so this year, in January 1st, 2025, those 10 codes became active, right, with single shot and continuous, unilateral, bilateral, and divided by body region rather than, right, here's a code for a QL1, here's a code for a QL2, here's a code for a QL3, and when we get to the QL23 some year, every time we do those codes, they want to survey the whole family. And so it puts a lot of codes at risk, and we're always trying to maintain value to the best of our ability.
I think the only other thing I would add is I just remember, I don't know if I highlighted on this one of the slides, again about proper documentation. So when you're using your primary diagnosis for trigger point injections, you can't use like fibromyalgia or like neuropathic pain. So you have to pick the diagnosis like myofascial pain syndrome or myofascial pain, something like that, because they won't pay for that.
Right, going for that, for example, cervicogenic headaches, cervical facet joints are involved. That's a cervical facet joint syndrome for the diagnosis. So cervicogenic headache, or just saying headache, and you make a cervical facet procedure, doesn't get recognized or billed for.
Yeah. And how many people went to the Rovenstein lecture this morning? Yeah, really outstanding lecture talking about data. But by the same token, he gave a phenomenal lecture about how we can use data to support the things that allow us to improve care. By the same token, understand that the federal government and all these insurers have a tremendous amount of data around us, right? And so there are codes that it says, there's what they call the NCCI, or the National Correct Coding Initiative. It says these codes can be built together, these codes can't be built together, right? These diagnoses will support the payment for this particular CPT code. These diagnoses will not, right? When we see excess utilization of various codes or other things, right, those things can be tracked down to the individual NPI, right? So we'll see weird things come through. So just out of curiosity, how many of you have done spinal accessory nerve blocks as part of your pain practice? Me neither, all right? All of a sudden, there was a dramatic uptick in the number of spinal accessory nerve blocks being done and billed to CMS. And we traced it down to a single family practice where it was being done by nurse practitioners in the state of Michigan, right? And ultimately, because none of us could come up with any rational indication for doing a spinal accessory nerve block for the treatment of pain, we recommended to CPT that they just eliminate the code, right? Rather than allow the continued misuse of the code and reputational damage that was occurring to pain physicians because of this inappropriate use of a code, right? But these things are being looked at all the time, right? And it's the same thing with all the other codes that we do it. So it's just, know that big data is being used both for us and to look over what we do, either well or not so well.
Thank you very much for joining us.